Good afternoon. My name is Marcelo Wolf from the University of Chile, Santiago, Chile. And with me is Dr. Beatrice Greenstein from Rio. And we are going to coordinate, be the co-chairs of this session. This is a special session because what we are going to do here now is to present papers that were submitted to the Congress, were accepted, and according to the model of presentation will be discussed together with the plenary sessions. And so we'll have 3 sessions for presentation here. Each one will be 15 minutes of presentation plus immediately after it's finished, 5 minutes of discussion. So Dr. Greenstein will will introduce the first presenter and the title of the presentation.
Great. So welcome to the session. It's my pleasure to introduce Dr. Larder Brendan. He will present to us the HIV treatment response prediction system, using the experience of treating tens of thousands of patients to guide optimal drug selection. So we will have about 15 minutes for the presentation, and then we will have some time for questions.
Okay, thanks very much. I guess everybody enjoyed their coffee break. And what I'm going to do is, in the next few minutes, is to basically describe what we've been doing at the RDI, how we've been modeling HIV treatment response, and then how we've now used that to formulate a system online, which is a free online system that anybody can really use to get these sort of predictions. So just by way of introduction, the RDI was launched in 2002 as a not-for-profit organisation, and it had this sort of mission, which was really to develop and make freely available a system to predict response to combination therapy against HIV as an aid to optimising and individualising HIV treatment. Just as an overview of what the current status is and what the RDI does, essentially we spent a number of years, and we're still doing this, accumulating data from sources all over the world. Currently we have a database which has more than 150,000 patients worth of data, with over about 1 million viral loads from more than 50 countries. We've been using the data to train computer models, mainly over recent years, models called random forests, to predict the probability of virological response to combination therapy. These models are validated with independent test sets, and I'll show you some data in a few minutes, and they're used to power this online HIV treatment response prediction system that we call HIV-TRePS. These are the key performance indicators. Our aim was for the system to be significantly more accurate a predictor of response than genotyping with rules-based interpretation, which is, I guess, the gold standard, particularly in resourced countries. And we wanted the system to be able to identify alternative drug combinations with an increased chance of success than those selected without the system. So what's the advantage? Why are we using computer modelling? Modelling is useful because the models can kind of learn by example. If you give them many thousands of patients' worth of examples in this case, they learn from extensive real clinical data. And as I said, in our case, we use thousands of patients' worth of data. They work well for complex interactions between multiple variables, and they've already been used fairly successfully in other clinical areas, for example, in oncology and cardiology. Now, crucially for the HIV experience, the models can give a quantitative prediction of viral load response to drug combinations, not to individual drugs, but actual combinations of drugs. So what do the models use to predict, to make their predictions? we use baseline viral load, CD4 count, and in some cases genotype, but this isn't necessary in some of the latest models we've developed. We used antiviral drug treatment history and the drugs in the new regimen and time to follow-up. All this information is packaged together in something we call a treatment change episode, or a TCE, and I'll talk about these a little, quite a lot. The TCEs are really designed around the time when a patient changes treatment, which is shown in green here with this arrow, where they've failed a treatment, changed therapy, and then they're on drugs on a new therapy. So around this time we collect treatment history during the failing time, baseline viral load, baseline CD4, genotype if it's available, but as I said, it's not necessary, then follow-up viral loads and the time to follow-up of these viral loads. And the output of the model is the probability of the follow-up viral loads going below 50 copies per mil. So in the development and testing of models, this is kind of what we've been doing and with different iterations. TCEs, or these data packages, are extracted from the database that meet the modeling criteria, and this crucially it means no missing data. So we include all the data from that package. The TCEs are randomly partitioned by patient into 90% for training and 10% for validation. So these are independent sets. And what we generate from this, from the modeling, is a so-called committee or a group of 10 models, and these are random forest models. And these are developed using a cross-validation scheme within the modeling. The baseline data then and the drugs in the new regimen are then used to, with the test cases, which are independent of the training set, to estimate the probability of response. So the committee average then says, well, this is the response we think will happen with these cases that we haven't seen before. And those predictions are compared with the actual response data on file. I'll show a few of these receiver operating characteristic curves, the ROC curves, just to orientate you, because this is really how we will present the data. When these curves are plotted, the sensitivity over 1 minus specificity, if you see a line like this dotted line here, that means the AUC, the area under the curve, is 0.5, which is total chance. So we want to see something better than that, and better than that is to the left-hand side of this curve. So the green, for example, shows improvement, and the red would be the sort of panacea, an AUC of 1, which would show a perfect prediction or 100% prediction. The green here shows a typical prediction that genotyping with rules-based algorithms tends to give an AUC of about 0.65. This set of curves shows a whole bunch of data from different models that we've produced over the last few years. These are models with or without genotype, and also compare how those models did with GSS from rule systems, which is genotypic sensitivity scores, basically rules-based algorithm systems. These are all they here, and this bunch of lines showing typical AUCs between 0.65-ish and 0.7, and overall accuracy of in the 60% range. And what we show here on the red curve are the models that use a genotype, and without a genotype, and the green curve are models with a genotype. These gave a typical AUCs of about 0.8 or greater, and accuracies of around about 80%. So you can see these are very different from the current genotyping plus rules. I'm just going to show you some data on our latest no genotype model, because I think this is particularly relevant perhaps for use in resource limited or in areas that don't have genotyping or can't afford genotyping. So the latest model is, again, based on 10 random forests. We use data from about 24,000 cases or patients of therapy change following virological failure. And these were multiple sources, largely from some Western sources, but included over 1,000 patients from Southern Africa. We divided these up and used just over 22,500 to train the models, and 1,000 were set aside for validation. There were 43 input variables in the models, which included baseline viral load, CD4 count, treatment history, drugs in the new regimen, and time to follow-up and follow-up viral load. And as I said before, the output was prediction of the probability of viral load going below 50 copies. These are the ROC curves showing, again, the comparison here with genotyping, which in this case really didn't look too good, which gave around about 0.6 AUC. And the tests from the no genotype models, which were all fairly similar. I point out one, which is this line here, this orange line, which was 100 independent patient TCEs from Southern Africa. And basically they performed pretty well with the models, similar to the other test sets, the more general test sets. The data sort of summarized, some of the data summarized here, showing the basically the models versus genotyping. This was about 350 cases from the 1,000 test set, where we also had the genotype. With the others, we didn't have the genotype. Basically showing that the average AUC for the genotyping systems was about 0.6, with an accuracy of about 55%, whereas the models were giving AUCs of 0.8, with accuracies of around about 75%, and these were all significantly different from the RF models. As I mentioned before, we particularly wanted to see how data from patients from Southern Africa would perform with this model. Obviously, well, in a lot of cases, genotyping is not available in that region. So to do this, we took baseline data from 100 of these test cases and input them into the models. These were cases that weren't used for the initial training of the models. The models made predictions of the probability of response to alternative 3-drug regimens, and these drug regimens comprised only those drugs that were available in the clinic at the time of the treatment change. And the outcome measure was the number or percent of cases for which alternative regimens were identified that were predicted to be effective, both for patients that failed and patients that were successful. This is a summary of the data. For all cases, the 100, we found in 76% of the cases there were alternative effective regimens. And in the failures, of which there were 48 failures out of the 100, 65% or 31, the models found effective alternative regimens that could be chosen from the clinics, the drugs in the clinics that were being used at the time. So to summarize that modeling study, these models accurately predicted virological response to a combination therapy without a genotype, and the AUC was approximately 0.8, so pretty reasonable numbers. These were significantly more accurate predictors of response than genotyping with rule-based interpretation, highly significant differences. And they were, as I just showed you, they were accurate for cases from Southern Africa as for other regions. And they were able to identify alternative regimens predicted to be effective for the majority of cases where the new regimen in the clinic failed. I'll just briefly summarize a couple of studies, two other recent studies that we've done. One was a prospective study, a clinical pilot study carried out in Canada, the US, and Italy. And in this, HIV experts were made salvage decision treatments with their patients using genotype and all the other data that they had at their disposal. They then received a prediction from the TRePS output, and the result of this is 1/3 of the treatment decisions were changed based on the report that came back from the modelling system. So it showed that it really had an influence over selection of regimens. The second study was a recent retrospective study of switching from first to second line therapy in an Indian cohort. And I'm just highlighting this because it's one way that the models can be used in terms of, we think, potential cost saving of drugs. And in this case, the models identify cost saving alternatives with greater probability of response in 88% of cases of actual failure in the clinic. So just to get on to some of the nitty-gritty of the HIV-TRePS system, this is basically how it works now online. When a patient requires a treatment change, viral load, CD4 counts around the time of change, treatment history, with or without genotype, are entered online. The models then that power the TRePS system predict viral load responses to thousands of alternative combinations in real time, and a PDF report is produced within a minute of the top 5 combinations. This is you probably won't be able to see this very well. This is a sample report with no genotype, and basically the information we'll hear is the information on the patient, and what's shown in this table below are the top 5 combinations that are predicted to, in this case, to work, as well as 2 combinations that the physician has input themselves, because they are the ones that they were thinking of using. And as well as a prediction of response, there's also a measure of variability as well in that response that's given. So a registered user of TRePS, so remember this is a free-to-use system, can obtain predictions of response for drug combinations that they plan to use. They can identify combinations most likely to work from alternatives in clinical use. They're able to rule out drugs for toxicity or unavailability, etc. And they can also input local drug costs and model alternatives within a certain budget to ask for drug combinations of a certain cost, and identify the least expensive regimens that are predicted by the system to actually work, and then store these cases for in their personal online archive. So just to summarize all of that, the computer models that we've generated can be accurate predictors of virological response even without a genotype. They're significantly more accurate than genotyping, and the models have the potential to avoid treatment failure by identifying effective, alternative, practical regimens. The system has the potential as well to save money by identifying less costly but effective combination therapy. But we must remember that the system supports but is not a substitute for clinical judgments. So my overall conclusion would be that the system has the potential to help optimize therapy in settings with limited resources where genotyping is less available or affordable, but viral load testing is common. And you can have a look at the actual system itself, and I encourage you to go and look at that online, and this is the URL. I'd just like to thank our data contributors, which there are many worldwide on this list, but you can see that on the poster 131, I think it is, in the other room. And just make a plea, actually, is that we need more data from the Americas. We really have very little data from Central and Southern America. And so any of you guys out there who have data sets that you'd like to contribute and like to collaborate with us, then we'd be most grateful. I'd like to acknowledge the hard work of Andy Revel, who put a lot of this together, Dan Coe, who does all the database work and the online work with the websites, and Dechao Wang, who does all of the modelling, and the NIAID for funding. Thanks very much.
Thanks very much, Brendan. That was a great presentation. So we are open for questions from the floor. Please.
Hello. Hi, Brendan.
Hi, Mario.
Great presentation. Maybe I missed something, but two things. One is models are as good as the data they get. So you're getting data from over 50 countries. So if you could elaborate a little bit on the QA/QC procedures you have to verify the quality of these data. And the second thing, I maybe missed what you presented, but what I saw you presenting was the probability of success of the model chose. But did you validate that with the cases that are submitted to you online, not the ones that received? I know that the cases you receive use part to make the model, part to validate it. But do you, outside validation, since people submitting the internet were not part of these groups, and see how helpful that was and how well it really predicted success in life outside these reference or research environments?
Right. I mean, they're from all sorts of environments, from clinical cohorts. But just to answer that question first, we thought long and hard about this, whether to try and collect outcome data from people who submit data online just to get predictions. And we decided not to, because of not really knowing how much we could trust it. So we don't actually do that. I mean, I think the most rigorous testing that we feel is very rigorous that we do are using independent test sets that the models haven't actually seen, but from similar clinical settings or geographical locations, like I described the Southern Africa one. And your first question was... Sorry about that. The quality control. Yes, the quality control, well, yes, we have a number of those in place, but we have criteria for the data that we actually choose to use for modelling in terms of it must be complete, must have obviously all the dates and drug names that we can recognise, viral load from tests that are recognisable, diagnostic tests, etc., etc. So from that point of view, I agree with you. I mean, modelling can get very tricky if you have sort of rubbish data, so you have rubbish in, rubbish out. But we do have other filters as well for what looks like non-adherence, where a patient will be changed drugs and viral load will just remain or go very, very high, for example, that just doesn't change. So it looks like the patient actually isn't taking the drugs. We do have adherence measures, but we don't currently use them because we haven't got those across the whole of the database, but they would be quite useful. And we feel that where the modelling is let down to an extent are data that comes in where there has been a degree of non-adherence with the patients.
One more question, please.
Hi. I have a specific question about how your algorithm or your model deals with people who failed on 3TC or FTC. Would that preclude the use of 3TC or FTC in a next regimen, or how do you deal with that?
Well, I mean, we let the models deal with it. I mean, the FTC and 3TC are modelled independently, and we're in the process of thinking about modelling where drugs have been used as fixed-dose combinations as well, and looking at the database to see if we have enough data to do that. Because it's a sort of iterative process, a modelling process, we can't really say, well, does it preclude use of FTC or 3TC after 3TC use, for example? And I would say, well, I hadn't looked in a lot of detail, but I'd say in some cases, a lot of cases not, and in some cases maybe. So it's the same with the non-nucleosides as well. So it's hard for us to predict, but then at the same time, that's why we're doing the modelling and letting computers do it. So.
Thanks.
Great. Thank you.